There we go. Okay, so again, please feel free if you have questions to go ahead and ask them. And hopefully everyone can hear me okay. I am just going to assume that everything is working unless somebody tells me otherwise, which may be dangerous and I may be talking to myself, but we'll hope for the best. So I just want to mention that I have no financial conflicts of interest, but I maybe have an intellectual conflict of interest in that I did recently serve as the clinical chair of the von Willebrand disease management guideline from ASH, ISTH, NHF, and WFH. And I do have research funding for my work from the National Heart, Lung, and Blood Institute and from the MAC Fund, which is the Midwest Athletes Against Childhood Cancer and Blood Disorders. All right, so objectives for today. Mainly, it's going to be discussion of treatment options for von Willebrand disease. I want to highlight a few things from the new evidence-based management guidelines and update a couple of novel therapies. I think that we are all disappointed that the exciting advances in von Willebrand disease aren't quite as profound as maybe some of the advances in hemophilia care, but hopefully we will get there. And then a very brief discussion of diagnosis. Okay, this is not meant to be an introduction to von Willebrand disease. I was told everyone's good with that, but I do want to remind people of the different types of von Willebrand disease because this does impact some of the treatment. And probably everyone knows this already, but there are three main types right now of von Willebrand disease. Type 1, which is the most common and is a quantitative defect in VWF. Type 2, which is a whole group of disorders of von Willebrand factor, where there's a dysfunction, a qualitative defect in the VWF. And then type 3, which is really the absence of VWF. And then because we can't make it this simple, we break down the type 2 variants, the qualitative defects, into 4 different categories, which are 2A, 2B, and then because apparently we can't do 2C and 2D, we had to skip a bunch of the alphabet and go to 2M and 2N. And yes, this does bring up the worry that maybe there's a C, D, E, F, G, H, I, J, K, L out there, but we're gonna hope not. So 2A, for people that have this, is a defect in the way the VWF multimers work. 2B is a gain of function, where the von Willebrand factor likes to bind platelets too well. Type 2M is kind of everything else. It's a problem with binding platelets or collagen, but the multimers are normal. And then 2N is an issue with factor VIII binding. So this is the technical classification. From a treatment standpoint, though, it's actually a little bit easier to think about von Willebrand disease as there's really 2 types. There's von Willebrand disease that you can use desmopressin as a treatment option for, which is most people with type 1 von Willebrand disease and occasionally type 2. And then there is von Willebrand disease that requires factor concentrate for treatment, which is most of the type 2, type 3, and some type 1 von Willebrand disease. So what are our treatment options? Desmopressin is probably the classic treatment for bleeding that is associated with type 1 von Willebrand disease. And what it does is it stimulates release of your stored up von Willebrand factor. So this really only works if you have some von Willebrand factor present, and preferably if that von Willebrand factor is totally normally functioning, like someone with type 1 von Willebrand disease. Since you only store so much von Willebrand factor at a time, one of the major limitations is that you can only give a couple of doses in a row. But the major advantage to desmopressin is it's easier to use than clotting factor because it does come in an intranasal form that you can just squirt up your nose without having to worry about IV access. In contrast, von Willebrand factor concentrate is currently only available as an IV treatment. The good news is it works for any type of von Willebrand disease, and you can give repeated doses without problems. You also don't have to worry about fluid restriction, which is nice. And it comes in plasma derived, meaning it's purified out of human blood. And then in the last 3 to 4 years, we've now had a product on the market that is lab made or recombinant. So going through these in a little more detail, desmopressin, there have been some recent issues, and I know people were worried about this. So intranasal desmopressin, which was marketed by CSL Behring under the brand name Stimate, has been a mainstay of our von Willebrand disease treatment for lots of people. And IV desmopressin is still available and currently not under any shortages. But the intranasal form called Stimate was recalled a couple of years ago by the manufacturer. And most other forms of intranasal desmopressin are not concentrated enough to use for von Willebrand disease. Incidentally, the other use for intranasal desmopressin is for bedwetting. So kids that have issues with bedwetting will often get a prescription for intranasal desmopressin, but it is a very, very, very dilute form, and you would have to squirt a lot of that up your nose to equal the former Stimate. Now, there is some good news. Well, the bad news first is that it does not sound like CSL Behring is going to pursue correcting the manufacturing problems, at least at this point. They were initially saying that it would be back on the market next year, but the updates do not seem promising. However, there is some good news. A company called Stack Pharma, based out of Colorado, has now made their own generic intranasal desmopressin, so the product formerly known as Stimate. They have approval for it, and the initial vials they were shipping had a very, very quick out date, meaning they were good for about a month. They are now shipping preparations that are good for 3 months, and the hope is that at some point soon they will have approval for vials that last for 6 months and then hopefully a year. These are smaller vials than the original Stimate vial, but the good news is it's still available, and they are selling it for reasonable prices to hemophilia treatment centers. So hopefully you will have some available near you if this is your medication of choice. And we are all very grateful that this company stepped up, because there are lots of people do not like desmopressin. It has a lot of non-fun side effects, but there are plenty of people with von Willebrand disease for whom this is their medicine of choice. And so it's great that we actually have some available for people that want it and need it. And they are, I'm not sure that they are selling it commercially, but they are definitely selling it to hemophilia treatment centers. So contact yours if this is something that you desire and or need. It's basically the exact same thing as Stimate, just in a smaller vial and made by a different company, so it doesn't have the brand name. But it is just as concentrated and appears to work just as well. In anticipation of the question, do you need to redo your whole Stimate trial? We have not been having people redo it, as it appears to be more or less the same product, but check with your doctor because your mileage may vary there. All right, factor issues. There are a couple of different clotting factor products that contain von Willebrand factor. The 2 most common in the United States are Humate-P and Willate. And then the newer recombinant or lab-made product is called von Willebrand. They are all currently IV, and I am not aware that anybody is working on a clotting factor concentrate that is not going to be IV. So this brings up the problem of infusions. It is possible to have patients, or for little kids, their families, learn to self-infuse. So if this is your product of choice, learning that can be helpful to save clinic time or ER visits and the accompanying cost, particularly if you live a longer distance from someplace that can do that for you. And that can also be helpful if this is your treatment of choice and you're going to be traveling or things like that. But right now, unfortunately, these all are IV products. Now, I want to mention a potential novel therapy that probably isn't going to be widely used for type 1 von Willebrand disease, but there are definitely people who have used this for the more severe forms of von Willebrand disease, like type 3, and it's worked. This is a drug that is marketed for hemophilia A, or factor VIII deficiency. And it is a very interesting drug. It is an antibody. It is a very strange protein that basically works like the complex of factor VIII and 9 to activate factor 10. The picture of it, I realize, makes it look a little like an alien, but it was basically engineered to mimic factor VIII and the way it works in the clotting cascade. And so because it kind of replaces factor VIII, it has been used for some type 3 von Willebrand disease. And the good news with this medication is it's given subcutaneously. So like a diabetes shot, like you're giving insulin. And those are very easy to give and pretty much can be given, teenagers can do it themselves. And then for little kids or people that are really needle phobic, a parent or somebody else can give it. This currently, again, is pretty much reserved for type 3 von Willebrand disease. And actually, I want to be careful using the word severe, because I think sometimes when we talk about von Willebrand disease, we're like, well, type 1 is the mild and type 3 is the severe, but the bleeding symptoms with any of these can be very significant. So just to qualify, the use of emicizumab has really so far only been in type 3. It is possible that this will be expanded, but right now this is an off-label use. But it's possible we could also craft some more interesting drugs that are given subcutaneously, which would definitely help with administration. Okay, this is the extent of my slide on gene therapy. I am mentioning it because it is there are a number of products for hemophilia, both for factor VIII and for factor 9 deficiency. This is the list of products that are currently available for von Willebrand disease. Part of the problem is that von Willebrand factor is a lot bigger than factor VIII and factor 9. It is gigantic. One could argue that that means it's more important, but clearly factor 9 is tiny. Factor VIII is a little bit bigger. Von Willebrand factor is huge. So it's not that people aren't trying, it's just that von Willebrand factor is a gigantic protein, and it is really hard to stick it into the cassettes used for gene therapy. The other part of the problem is that von Willebrand factor genetics are not quite as straightforward as hemophilia genetics. So for type 3 and type 2 von Willebrand disease, the genetics are pretty straightforward, but we'll talk about this in the diagnosis section. Type 1 von Willebrand disease, it's not always that clear. And so even fixing the von Willebrand factor might not completely alleviate all of the symptoms. So it's possible that this will be on the horizon someday, but don't hold your breath right now, I guess is what I'm saying. Okay. So sometimes we think of it as just, well, your only options are desmopressin or factor. But I do want to mention a few other treatments that sometimes get forgotten, with the caveat that all of these have different side effects and different inconveniences, but at least knowing about all the options give you chances to try things and see what works, because it turns out that everyone's bleeding is very individual. And so some people, and everyone's experience of side effects is very individual. So some of these may work really awesome, while others may not. So the big category that we often forget about is something called anti-fibrinolytic therapy. And basically what these are is clot stabilizer medicines. They do not influence your von Willebrand factor, so they're not going to change your VWF level. But what they do is prevent the clot from breaking down. The two in the US are Amicar and Lystata, or tranexamic acid. And these work beautifully for the mucosal bleeding that is common in von Willebrand disease. So heavy periods, nosebleeds, mouth bleeding, particularly after tooth extraction, these can be really good for. And basically they just prevent the clot from being broken down. And in the little picture, there is an enzyme called plasminogen, which is the blue blob. And that actually is the scissors that cuts up your blood clot. And the way Amicar and Lystata work is they block the site. They basically hold the scissors closed, so the scissors can't work. Now, they do come with their own side effects, and these can be serious for some people. Headaches, dizziness, and upset stomach are the most common. I would say that there are the two different brands right now, and some people will have side effects with one but not the other. So even if you have issues with one, it may be worth trying the other just to see. And the good news is these are oral, they're pills. So they do also come in IV forms. Although, because of course we have to have some drug shortages, the IV Amicar version is currently under a manufacturing shortage, but tranexamic acid appears to be in good supply. And then they are both available orally. And the tranexamic acid is generally pills, but Amicar comes as a liquid. And you can even, if you don't, for bleeding in the mouth, you can even not even bother to swallow it. So for dental extractions like wisdom teeth, you can just swish it around your mouth and spit it out, which does reduce the side effects a little bit. But again, I don't want to minimize side effects that people might have with these because sometimes they are not inconsequential. Okay, I realize that this audience is probably not all women, but since heavy menstrual bleeding is so common in persons who menstruate with von Willebrand disease, I just want to mention the option of hormone therapy. Again, this doesn't necessarily directly affect the underlying von Willebrand factor, but it can definitely improve the symptoms associated with the heavy bleeding. And these come in a variety of methods. There's the traditional pill, but for people that have issues swallowing pills, there's a patch, there's a shot, although I'm a pediatrician, I see a lot of teenagers, and for some reason, no one's ever excited about getting more shots. IUDs can be very useful, and they may actually be more effective than our bleeding disorder specific treatments because they affect the amount of blood in the uterine lining and therefore the amount of blood that's being shed. Again, there are side effects and acceptability issues. There is also, for people with really, really, really bad nosebleeds, sometimes we will use topical estrogen and use that in the nasal cavity to try and help control the nosebleeds. Most of the data on estrogen and hormone therapy is for persons who menstruate. And so there really isn't a lot of data out there on hormone therapy or symptom management post-menopause. I will say that this is one of the areas that came out. NHF recently had a state of the science on von Willebrand factor, and aging and von Willebrand disease was considered a high priority area to try and figure out. But at present, we really just don't have data on what to do in those situations. So would refer people to their GYN to talk through it from a general perspective as opposed to a vWD specific perspective. And then the other therapy that I want to mention is iron. So anyone who has extra bleeding has the risk of becoming iron deficient. And for von Willebrand disease, the two areas where this is most common are people who have heavy periods and people who have frequent nosebleeds. And occasionally adults with GI bleeding will also fall into this category. But many people with bleeding will have low iron stores. And I want to mention the two laboratory tests that we frequently do to diagnose this. And again, my guess is that you are all very familiar with these, but just in case there is somebody out there who's had these done and isn't quite sure how to interpret them, The two most common things we look at are the ferritin and the hemoglobin. Ferritin is a marker of how much iron you have stored in your body. And ideally, you want that number to be over 20. And there are some people that seem to be really sensitive to low ferritin levels, and so you may want to push that even higher. The hemoglobin is our typical measure of the number of red blood cells. And for adults, you typically want this over 12 for women and 13 or 14 for men. The normal ranges for children do vary a little bit with age. So the number may be okay if it's a little bit lower in babies and young children, but sort of generally that's where you want those to be. And so if you have a lot of bleeding, watching those iron levels can be helpful, especially if people are having symptoms, they're super tired, super fatigued, just not feeling quite right. There are pills, of course, to supplement your iron. I do want to mention that over the last couple of years, we do have a couple of IV iron preparations. In the old days, years ago, people used to have really bad allergic reactions to all the IV irons available. And so we used to never use it. But more recently, there's a couple of preparations that don't seem to trigger that level of allergy. Occasionally, people will get some hives, but they're definitely much more available. So if you are somebody that feels like you are always taking iron pills and it's just not working, be aware that that's an option. And then for younger people or people that just don't tolerate the generic ferrous sulfate pills, there are a variety of oral supplements. For pediatrics in particular, I want to mention one that we often have good luck with. It's a company called Novoferrum, and they market their liquid iron as tasty and yummy. I don't know if anyone else here has tried it. I wouldn't probably go so far as to say that it's yummy, but I would say that it definitely tastes better than your standard ferrous sulfate drops, and it definitely does not smell as nasty. So if you have a young child that you're trying to get to take liquid iron, this may be worth looking into. Right now, they're available through Amazon, and I don't think Walgreens stocks it yet, but I know that's been discussed. But it is a little more expensive, and it's not always covered by insurance. So that's the downside to these. Okay. All right. So that's kind of the overview of what is available. I want to digress for a few minutes and talk about the new guidelines on the management of von Willebrand disease, partly just because I had a chance to be involved in this. And so I think it's fun to kind of pull back the curtain and let you guys see what was behind it, but also because these are the recommendations and a couple of them are areas that people are definitely interested in. There's actually one on diagnosis and one on management. And most of what I'm focusing on today is management because that's where most of the questions came in. All right, this was a collaborative project. There were actually 4 different organizations that wanted to do a von Willebrand guideline, and fortunately for us, instead of doing 4 separate ones, they agreed to do one together. So it's ASH, the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, which is US-based, and then the World Federation of Hemophilia. And I do want to mention that there was very strict conflict of interest disclosure and management. Most of the panelists had no direct financial interests in companies with products that could be potentially affected by the guidelines. And anyone with a conflict was not allowed to vote on the recommendations, and no industry funding or sponsorship was allowed. And I think this is important, particularly when we talk about prophylaxis, because we did end up recommending prophylaxis. And so it's good that we weren't in the employ of a pharmaceutical company at the time. The general principles were that the goal was to improve quality of life for patients with von Willebrand disease. And patient input was critical and obtained through several areas. There were patient members on each panel. There was a stakeholder survey, which it's entirely possible that people in this audience participated in which case, thank you very much, especially for the 9,000 comments that we got to read through. where I learned that nobody likes desmopressin. And then there was a public comment period where people could also weigh in on the final recommendations. And this was with the goal of facilitating clinical decision-making regarding the diagnosis and management of von Willebrand disease, with the goal of contributing to better health outcomes, quality of life, and I mean, we're going to keep coming back to that because that ended up being one of the major considerations, and health equity. So some of these were also worded for insurance companies. Increase access to appropriate diagnostic testing and therapeutic options, identify research priorities, and this ended up being another major area because it turns out that we do not have a lot of data in some of these areas, which is really quite pathetic given how prevalent von Willebrand disease is, but at least now we know where some of the big gaps are. And then guide healthcare providers, patients, payers, insurance companies, and other stakeholders as to priority focus areas. And the questions chosen came out of the stakeholder survey. So this was based on, the responses were approximately half people in medicine and half patients and caregivers. So this wasn't just a group of physicians sitting around thinking of what they thought was the important areas. However, we were limited in what we could cover. So there are a lot of areas that did not get covered that will hopefully get picked up on the next iteration of this. Okay, the panels themselves, there was a diagnosis panel and a management panel. They were geographically diverse, 10 countries and 4 continents, although the US was heavily represented. Academic and community hematologists, methodology experts to help interpret the data, content experts from other relevant fields, such as gynecology in particular. We also had a dentist on the panel for the oral bleeding, and then patient representatives. So there were 7 total patient representatives with either personal experience, family experience, or both of von Willebrand disease, diverse with respect to gender, type of von Willebrand disease, disease severity, and disease experience. And again, it was possibly a little more heavily weighted toward the US, but we did have patient representatives from Europe and actually Australia to provide their input. And I do, for anyone who's tried to read these, I do want to interpret the recommendations for a moment. When you're doing these evidence-based guidelines, where you actually look at the quality of the evidence, there are 2 types of recommendations that can come out. There are strong recommendations and there are conditional recommendations. And so the difference between these is for a strong recommendation, which is worded as the panel recommends. This means that almost everybody would want whatever is being recommended, and clinicians would think that almost everybody should receive whatever that intervention is. On the other hand, a conditional recommendation, a majority of people would probably want, but many would not. And for clinicians, different choices would be appropriate for different patients, depending on their values and preferences. And this is a time when shared decision-making is important to look at the different options. And I will give you a spoiler alert. All of the management recommendations were conditional. There was nothing where the evidence was strong enough and the potential issues were clear enough that we could say everybody needs to get this. And part of that is based on what the actual evidence was. Part of that is based on different values and preferences. Okay, since one of the things that came out of the stakeholder survey was women's bleeding issues were considered a high priority for many people, I'm going to mention there are 2 recommendations for heavy period management. This is basically first-line therapy with the understanding that if this does not work, hopefully people have access to a OBGYN and hematologist that can help troubleshoot. But the first-line management recommendation is that the panel suggests using either hormonal therapy, combined hormonal contraception, or levonorgestrel releasing IUD is the Mirena, or tranexamic acid over the use of desmopressin to treat women with von Willebrand disease or persons who menstruate with von Willebrand disease and heavy menstrual bleeding who do not wish to conceive. And we will address people who wish to conceive in a moment. And the issue here is that the quality of life may be most improved with hormones. There's some indirect evidence that the hormone therapy is going to be the most likely to reduce the amount of bleeding. But there are also a lot of people that have personal values and beliefs that make use of hormone therapy less acceptable. And the side effects of tranexamic acid were judged to be overall least harmful and least undesirable compared to desmopressin. It is also true that in most of the world, tranexamic acid is extremely cheap. And so there are also health equity issues here that bumped tranexamic acid and hormones up over desmopressin. Now, I want to put the caveat in here that everybody has individual responses to these medications. So this is not to say you cannot use desmopressin if that's the medicine that works best to control your periods. This is just on a population level. You are probably going to derive the most benefit from either hormones or tranexamic acid with the least side effects. But if those don't work, or if there are reasons you don't want to use them, there are other options. Now, if this is somebody who wishes to conceive, the recommendation is tranexamic acid over desmopressin, because if you're trying to get pregnant, hormone therapy would not be appropriate. And the reason I'm dividing these up is because I think it's also important that we recognize that somebody may have been on hormone therapy for a long time, stops to try to get pregnant, and if you have significant bleeding, we do still need to help out with that bleeding while someone is trying to get pregnant. You don't just say, okay, well, I'll just accept horrendous bleeding during this period of time. And the data that went into this, there is some data that suggests anti-fibrinolytic therapy in general works better than desmopressin, which I will show you. But everyone responds differently. So it was important to leave room for individualized therapy. And there is a recommendation that people work with their hematologist and gynecologist to optimize therapy, because we also know that many people do not necessarily get perfect results with first-line therapy. So this is not a choose something and forget about it situation. This is a choose something, try it, see what the effects are, see what the improvement is, see what the side effects are, and then change it if need be. And then I do want to mention what a normal period is actually defined as, because for a lot of people, especially if von Willebrand disease runs in the family, you may be surrounded by women who have heavy periods, and that may be what's considered normal. So if that's what you're used to, sometimes people don't think that their periods are heavy when in reality they are. And so we actually have a definition of normal. Normal should be 7 days or less, and one should be able to get by with changing their protection, pad or tampon or whatnot, no more frequently than every 2 hours. So, and of course, there are definitely, especially if you're a teenager in high school, people who will pop in the bathroom every hour just in case. But this is, if it's soaked in 2 hours, that would be considered heavy bleeding. So if that is the case, and you have been considering your period normal for all these years, we should talk, or you and your doctor should talk. All right. And I put this slide up. This is more of an education talk to clinicians slide, but really this, and everyone in this audience that has experienced heavy menstrual bleeding knows this, but somebody actually did a study on the quality of life with heavy periods. And this is a really almost horrifying graph, because it shows the immense effect of heavy periods on quality of life. This is often, and many of the side effects in von Willebrand disease are not necessarily considered life-threatening. But if you look at this graph, there was effects on family life, vacation, leisure activities in 3/4 of the women in this study. Prevention of daily activities affected social relations in over half of the patients on this study. So I think, sometimes we don't consider the bleeding symptoms in von Willebrand disease to be severe. And especially with type 1 von Willebrand disease, sometimes we do, and I am at fault here too, when you say, oh, it's mild von Willebrand disease. But I wouldn't consider having 75% of people have affected family life and vacation as necessarily mild. So it is perfectly acceptable to consider treatment in these situations to improve quality of life. This is the literally one randomized study on treatment of heavy menstrual bleeding. And for those of you that don't follow clinical research studies, randomized controlled trials are considered the gold standard, meaning that's the best evidence you can possibly achieve. And we do not have a lot of those for von Willebrand disease. So this is the only one we have, and it's a little old, but basically they took women with heavy periods and randomized them to either desmopressin or tranexamic acid, which is one of those anti-fibrinolytic therapies, and measured how much menstrual bleeding they had using the PBAC, which is our y-axis, basically it's an assessment of how heavy your bleeding is. The pictorial blood assessment chart, and basically it's little pictures of a pad and a tampon and how full they are. The actual gold standard for the FDA is to measure the actual blood, which is why there are not more randomized controlled trials in management of heavy periods, because no one wants to mail all their sanitary products back to the research coordinators. And probably the research coordinators don't really want to receive those packages either. But this is basically just asking women how many pads and tampons you filled up. And just so you know, it should be down here at 80 to 100. So people still had heavy menstrual bleeding on this, but the fastest decline, the sharpest slopes were the dotted lines, which were with tranexamic acid. And some of the people with intranasal desmopressin actually had worsening bleeding. So again, this is a general recommendation. So your mileage may vary. And so if you're one of the people that gets better results with desmopressin, that is still a valid experience. But in general, this is what contributed also to the tranexamic acid as first-line therapy prior to using desmopressin. Okay, the other area that I want to spend some time in is the prophylaxis recommendation. So the actual recommendation states that in patients with von Willebrand disease with a history of severe and frequent bleeds, the guideline panel suggests using long-term prophylaxis rather than no prophylaxis. Again, it's a conditional recommendation, meaning we're not saying everybody requires this, but we're saying it should definitely be considered. Bleeding symptoms and the need for prophylaxis should be periodically assessed. And although long-term prophylaxis is not as common in von Willebrand disease as it is in hemophilia, there are a substantial number of patients with a severe bleeding phenotype who could benefit from prophylaxis, probably with von Willebrand factor containing concentrates, because it's hard to do prophy with desmopressin. Okay, let's break down all the issues here. So you will notice that there is no specific definition for severe and frequent bleeding. And part of that is intentional, because what is severe and what is frequent may vary from person to person. And so we didn't want to make people fit a specific checklist in order to qualify. And there is no statement that this is only for type 3 von Willebrand disease, because there are plenty of patients with type 1 and type 2 von Willebrand disease diagnoses that do experience severe and frequent bleeding. And different patients will place different priorities on bleeding versus treatment. This situation would be a lot easier if we had a well-tolerated pill or subcutaneous treatment that would improve von Willebrand factor levels. But since we don't, prophylaxis right now is really committing people to periodic IV therapy, which has a cost associated with it. It has an inconvenience associated with it. And so it's not necessarily something that everyone wants to commit to. And There are some people whose bleeding symptoms are so intolerable that it's worth it, but we did not feel that there was enough evidence to say this has to be done by everybody. But it is something that should definitely be considered. The specific areas that were called out were epistaxis, joint bleeding, heavy menstrual bleeding, and GI bleeding. And the heavy menstrual bleeding, so the other symptoms are obviously all the time. Heavy menstrual bleeding, it may be what's called episodic prophylaxis, where you're doing treatment only at certain times of the month, but it's still prophylaxis with the intention of preventing bleeding. Treatment right now requires IV access. It often, for many people, requires a hospital visit. Older children and adults can be taught to infuse themselves. And some centers will have an infusion nurse who may be able to come to the house or go to school to infuse. But we also recognize that not everybody has that easy access. And in the United States in particular, there's a lot of big expanses of area where you may not be within 5 or 10 or 20 minutes of a hospital that you can go get an IV therapy. And many people can be taught to infuse themselves, but it's not universal. Very small children, it's difficult. Adults, one of the problems if you've had a lot of joint bleeds is you may not have the mobility to be able to infuse yourself. Not everybody has a family member that can be taught to do it for them. So it's unfortunately not a universal fix to the solution. There are a lot of specific questions, and I'll pretty much tell you this entire slide, there's no ideal answer to all these questions. And some of that is because everyone's situation is going to vary and different people will have different priorities. But when should you start prophylaxis is definitely a question that doctors should be addressing with their patients if they have significant bleeding. And this is going to depend a little bit on what the effect is of quality of life. If you have bad nosebleeds or heavy periods, how is it affecting your ability to do your daily activities, your energy level? And for little kids, I see a lot of little kids with bad nosebleeds, is it interfering with school? That is another important question. And then what are the downsides to it? So for people that do not have easy access to infusion or where there's going to be a gigantic cost, that may have to be weighed. But for people that know how to self-infuse, this may be a much easier equation. Should prophylaxis be used for nosebleeds? I think absolutely. Again, if the nosebleeds are 5 minutes once a month, it's probably not something that you're going to need to commit to. But if the nosebleeds are affecting quality of life, that is a legitimate question. Should prophylaxis be used for heavy periods? Again, quite possibly in many situations. This is something that is especially helpful for people that can't do estrogen, can't do hormone therapy for whatever reason, because then your options are pretty much limited to desmopressin and tranexamic acid. And we have lots of people who have side effects or issues with both of those. The anti-fibrinolytics, Amicar and Lysata in particular, can cause stomach problems, and desmopressin, anyone who's taken it can probably give better than I the litany of side effects that causes. So sometimes in those situations, people would rather do an IV factor than either of those options, even though the IV factor is harder to infuse. Are these bleeding symptoms severe enough to warrant prophylaxis? So again, this comes back to the definition being a little bit intentionally vague. Part of this, again, we got a lot of accusations that the guidelines were too US centric, but it is true in the US, many people are dependent on their insurance company authorizing their medications. So we did not want to have a checklist of conditions you had to meet in order to qualify for prophylaxis, because that is going to be different from person to person. And so it seemed like not a good idea to say you had to have, nosebleeds bad enough to cause you to have severe anemia, because there are some people who will want to be on prophy for nosebleeds just because it's affecting their quality of life. Same for heavy periods. And again, there are no super good measurements of heavy periods other than patient report. And so we wanted to make sure that people weren't going to get, we wanted to make sure people would be, the insurance companies would reimburse for these therapies. And then what is the effect of quality of life with versus without prophy? And I think this may be one of the more important questions because that is going to vary. And so somebody whose nosebleeds are bad enough to be causing severe anemia, missed school, missed work, missed social activities, the annoyance of having to do an IV infusion may be worth it. For somebody who the nosebleeds are happening just as frequently, but maybe not causing those same effects, the prophy may not be worth it. And the hope is that at some point we will have options that are not IV factor, but since right now that is the option, that's kind of the equation people are looking at, and that can be a very individual decision. So this is where that discussion of what the risks and benefits are with your doctor is so important. And possibly if it's with a child, the discussion from the parent's perspective, maybe from teachers' perspectives, what things the child can participate in. And this is a discussion that needs to keep happening. So the actual recommendation does state periodic evaluation of that symptom quality of life inconvenience balance. I think there's big life changes that happen where this may need to be reevaluated. Kids leaving the home and going off to college or school or moving to a new job. And even for adults, changing jobs may, or changing locations may change this equation. Sports participation. We definitely have people who are more interested in prophy because it allows them to do certain things. And if that certain thing, like a sports activity, disappears as your life changes, some of us become extremely inactive and change to a desk, there is no longer that stress. And so again, that may change the equation. But this is definitely something that, again, much like the hormone therapy, is not a pick something and forget about it. It's a continued discussion as there are life changes and as you may be in a new situation and this equation of risk benefits may change. And I certainly hope that this equation will change because eventually we'll have some cool new therapies, but unfortunately that is not today. There are a couple of recommendations surrounding surgery. So minor surgery, and there are actual definitions for what constitutes minor versus major surgery, but minor surgery, the goal is to get levels to normal with something, desmopressin or factor. And for most minor surgeries, especially those involving mucosal surfaces like a tonsillectomy or a tooth extraction, adding tranexamic acid. There is sadly not a lot of data about this, but the judgment was that that would most likely be helpful. And individualized therapy plans should consider the bleeding risk for specific procedures. Local hemostatic measures should be used when possible, especially for dental surgery. They can do topical thrombin, things to prevent bleeding that don't have side effects, unlike all our other drugs. And the thinking here is that combination therapy may give you more side effects, but it's also more likely to decrease bleeding risks. And you get some synergy with that addition of the tranexamic acid. And the goal of treatment is to prevent bleeding, because even quote unquote minor surgery can lead to significant bleeding. In patients who have a fairly high von Willebrand level, so baseline over 30, you can actually, for minor surgery, get by potentially with tranexamic acid alone, which eliminates having to give desmopressin for some of these procedures. And the expense and side effects of desmopressin make anti-fibrinolytic therapy both lower cost and lower risk. And the thinking behind this recommendation was the high value of avoiding the burden of extra therapy in this particular patient population. But again, these are going to be individualized discussions depending on the surgery. and a person's previous history of bleeding symptoms. So there may be people who have a lot of bleeding where you wouldn't want to do this, but in somebody who doesn't have that kind of history, it's reasonable to omit the desmopressin, which is very exciting. Okay, major surgery was also an area that we felt we had to have something, and it was desired that there be a recommendation. And again, there's not a lot of data on what levels should be targeted, but extrapolating from some of the hemophilia literature and from the factor product data that was available on treatment of surgeries, the recommendation is to keep both the factor VIII and von Willebrand factor levels in the normal range for at least 3 days and possibly longer. And the goal is to keep them both up, but the duration and the specific trough levels are going to vary depending on the type of surgery. So general treatment considerations. Patients with type 1 von Willebrand disease may be getting treatment with desmopressin. Type 3 and most type 2 von Willebrand disease will require factor. And the requirement for monitoring levels allows people to get their surgery at a hospital that's actually capable of monitoring, which unfortunately is not everywhere. And then people should keep in mind that you may also want additional treatment, such as anti-fibrinolytic therapy in these situations. There may be some surgeries where more than 3 days is appropriate, but that was sort of the minimal effective therapy consideration. Okay. The other aging area that we actually did have a specific question on was antithrombotic therapy. So this recommendation is for patients with von Willebrand disease and cardiovascular disease. So this would be people with histories of heart attack, stroke, things like that, who require treatment with antiplatelet agents or anticoagulation therapy. And in this case, there's a specific recommendation that the panel suggests giving the necessary antiplatelet or anticoagulation therapy over withholding treatment. Definitely individualized discussion of risks benefits should happen. And ideally, this is a multidisciplinary talk with the patient, the cardiovascular medicine specialist, and the hematologist, and possibly your primary doctor, and periodic reassessment of bleeding risk. And this is recognizing that some patients, particularly with type 2 or 3 von Willebrand disease, may benefit from prophylaxis to prevent bleeding while they're on antithrombotic therapy. So the issues here, there are some studies, population studies, that suggest patients with von Willebrand disease are at less risk of heart attack or stroke. So you do get some benefit from having von Willebrand disease. But in the US, we have an aging population. There are lots of other risk factors that go into heart attack and stroke. And so it means these do occur in people who also have von Willebrand disease. And the goal here was to make sure that patients with von Willebrand disease weren't denied the state-of-the-art treatment for their cardiovascular condition just because they have a bleeding disorder. It is true that you may need to be on prophy while you're on these therapies, but the concern was that there are people that are at risk of complications, a second heart attack, progressive stroke, things like that, that aren't being treated because they have von Willebrand disease and they're thought to be immune from these problems. Or the thought is that, well, your bleeding disorder means you can't get these. And so we wanted to make sure that if somebody with von Willebrand disease does have a heart attack and is supposed to be on an antiplatelet agent, aspirin or clopidogrel or one of those, that they actually get the state-of-the-art treatment and not have that withheld. Again, it's a conditional recommendation, so it's a discussion of the risks and benefits. There may be people who have severe bleeding who don't want to participate in that therapy. There may be people who have a really, really, really increased risk of a heart attack or a stroke who really, really, really want to avail themselves of the option of having that state-of-the-art therapy. Okay. I had some questions about diagnosis. My favorite question was about how to simplify the diagnosis of von Willebrand disease. And so I can say that this was addressed by the diagnosis guideline. And you're going to love the simplification of the diagnosis. Here it is, the suggested algorithm for von Willebrand disease testing. Nice and simple, right? Enjoy. So the problem is diagnosis of von Willebrand disease is not super amenable to a single test. And because there's all these different types, it is not super amenable to a single statement. So there really isn't a single test that you can accurately diagnose in all situations. And I unfortunately don't see that changing. There is a recommendation for use of a newer von Willebrand factor activity assay that really should help reduce diagnostic errors. Lab handling remains an issue. So I have this paper, but I forgot to pull a picture of it. There's an old paper on misdiagnosis of von Willebrand disease by Milkbox. That may be only a thing in the Midwest. I don't know if that's, those were done in New England, but people used to have these milk boxes outside their doors. And so the clinic would throw the labs in the milk box for the postal person to pick up. And what happens, at least in winter in Wisconsin, is those blood samples get pretty chilled. And basically that precipitates out all your von Willebrand factor. And so your labs come back saying you have von Willebrand disease, but it's really just because the sample was sitting out in the cold waiting to be picked up. And sadly, this still happens. And so the diagnostic test itself is only as good as the blood sample. The other problem with diagnosis of von Willebrand disease is that stress can affect the levels and physiologic stress. So newborns can have physiologic stress due to just being born. And so for somebody, if you make von Willebrand factor, like your classic type 1, if you were to test somebody right after they're born, those levels might be normal. So if you're doing family testing, the recommendation is to wait till somebody is a few months old until getting those labs. And I will often wait till somebody's a year old because generally most pediatricians will check blood at about a year of age anyways. So you might as well wait till you're getting blood done for something else, unless there's a procedure that needs to happen in the meantime. And then stress can also confound the levels at any time. This is a major problem in pediatrics because it turns out most kids don't like getting their blood drawn, but is also a problem anywhere. And it's a problem if you have other underlying medical conditions because there are autoimmune conditions like lupus can raise your levels. Inflammatory bowel disease can raise your levels. So making this diagnosis is challenging on a number of other levels besides the actual lab test. And I don't have a good workaround for that, other than clinicians just being aware that these can influence levels. The issue of family, and this where it particularly confounds things, is family testing. So family testing is recommended for anyone with bleeding symptoms or at risk of bleeding, like you're going into a major surgery. But since stress can affect the levels, those results can sometimes be hard to interpret, particularly if the diagnosis in the family is type 1 von Willebrand disease. Type 3 is not usually a diagnostic challenge because you don't have von Willebrand factor. And the type 2 variants are much more amenable to being diagnosed more easily. But since type 1 is the most common, that's usually what we're looking for. That's the one that can be tricky. And then unfortunately, the other issue is that von Willebrand factor levels increase with age. And we know they increase throughout adulthood. That was a known fact. But what we also now know is that the younger children actually tend to run lower levels. And this is a study that was done in children undergoing tonsillectomy. So these were healthy children and they had their blood drawn while they were under anesthesia for their tonsillectomy, because it's also hard to get healthy children to volunteer to get their blood drawn for any reason. But they had to have an IV placed for their sedation. So in this particular case, we were able to get blood. Generally, the cutoff for von Willebrand disease is a level under 50. And you can see in the kids less than age 6, there were a number of healthy children who did not have a bleeding history, who had levels in the 30s and 40s. And that number dropped off significantly once they were over 10. And the mean, the average von Willebrand factor level is supposed to be 100. Well, it's exactly 100 in the teenagers. The little kids had means of around 80. And it was because there were a lot of people with low levels pulling those numbers down. And these are presumably healthy children. So again, this confounds family testing because you may get a normal result, or you may get a low result in somebody who's actually normal. And then vice versa, you may get a normal result in somebody that has it but is stressed. So I do want to cover the diagnostic dilemma recommendation for type 1 von Willebrand disease. So this recommendation states that the panel recommends that a von Willebrand factor level of less than 30 qualify for a diagnosis of type 1 von Willebrand disease no matter what. And in patients with abnormal bleeding, a VWF level of less than 50 would confirm the diagnosis of von Willebrand disease. And this was actually a strong recommendation with the goal that there was a high priority in not missing a diagnosis in order to make sure treatment and prevention of bleeding gets obtained. And definitive diagnosis helps ensure access to care for people with a bleeding phenotype. So this may help for adults. It's still a little tricky for children. So there are situations where we decide we want to do repeat testing, or where somebody is low and we may suggest let's treat if they need surgery, but also consider if the levels increase and somebody doesn't have symptoms as they get older, that this may not be their actual diagnosis. So I know this really only makes the waters murkier. It doesn't necessarily simplify things, but the goal is to make sure that more people have access to care than not. Okay, and then the last area I want to cover is genetic testing. So many diseases now are diagnosed by genetic testing and not by other lab tests, plasma, blood samples. So the guidelines were specific about genetic testing for some of the type 2 variants. And I think that's where we really have the most evidence for when genetic testing is useful. Specifically, type 2B and type 2N are very amenable to a genetic diagnosis. Type 3 von Willebrand disease, again, this isn't usually a diagnostic challenge. We're clear that it's type 3, but genetic testing in that case may be really helpful for family planning and for diagnosis of family members. Type 1 von Willebrand disease remains a challenge, to say the least. So this is the von Willebrand gene in cartoon form. The type 2 variants are very committed to just being in a certain area. The defects in type 1 and type 3 von Willebrand disease can be anywhere. And there's a lot of variability in the von Willebrand factor gene because it's so big. So those are a lot harder to pin down. The other problem is that about a third of patients with type 1 von Willebrand disease don't have a genetic change in their von Willebrand factor gene. And this number is pretty consistent across groups, although I will admit that the areas that have done these studies are pretty heavily biased towards Northern Europeans. But we are definitely missing a genetic variant in many people with type 1 von Willebrand disease. There are other genes that can cause issues with your von Willebrand factor protein. This is a fairly up-to-date list of the ones that have been really well classified. But the problem is that we probably don't understand all the ways it can be modified. So it's not really amenable to an easy genetic test. And this is the other problem with gene therapy. If we're not sure which of these genes we need to fix, it makes type 1 much less amenable to gene therapy as the ultimate solution for symptoms. Okay, and that's it. So in summary, there are new guidelines regarding diagnosis and management of von Willebrand disease, but there remains a lack of evidence in many areas. So there is a lot of room for patient preference in treatment, and I definitely want people to hear that, because there are several options, and so it's not that you're committed to one particular one. And quality of life is a very important treatment consideration. Diagnosis of von Willebrand disease remains a challenge, and I apologize that we have not simplified it more. So I want to acknowledge the amazing co-chairs on the von Willebrand guideline panel, Nathan, Paula, and Reem, all the other people that worked on this, my lab, and I will stop there, and hopefully I have left enough time for questions. So please ask them. And I will stop share. Except this probably means that my face is really big on the screen in there, so maybe I should put the slides back up.
You look great. Thank you so much, Dr. Flood. That was incredible. Your presentation, humor, everything about that in education, I think was fantastic. I'm not sure you can hear, but there was lots of laughs with certain things in there. So this is questions here. So if you have a question, it has to go through my computer so I could get the mic, but we'll just leave it. If you're watching virtually, you can put the question in the chat and we can read that as well. So I'm going to leave it up to everyone. Any questions? Yes, Rachel.
So I'm wondering, I have two questions.
You may have to come up here, Rachel. Yeah, sorry.
So I am wondering, two questions. So to go back to children, like children who are asymptomatic, but with a family history, am I right that we're getting the sense that just sort of getting a baseline level at some point after the first few months of life is sufficient?
Yeah, so that, I wish there was a sense, so that this is going to be like the long-winded answer. I think it's definitely reasonable to get a baseline level, with the caveat that if that baseline level is really, really high and you're worried that it was a stressed sample, if that child starts having symptoms when they're older, you may want to retest. And if it's slightly low, there is a chance that it could still be normal for that baby. But if there's a family history and the level comes back low, we usually do a presumptive diagnosis. And if surgery was needed, I would probably treat on the basis of the family history, knowing that it is likely that it is a true diagnosis.
That's
so
crystal clear. Thank you.
I think if you have somebody who has a family member that's affected, but is totally healthy, you could also delay testing until they're a little older, especially if they weren't due for any procedures, needing anything done, didn't have any issues. Certainly for people who are at risk of heavy periods, I do recommend looking into it. And just because the risk of heavy periods and the effect on quality of life is so great that if we can do something to treat it, that's always or often helpful. But most of the time, you're going to get a decent baseline and an answer one way or another.
Okay, thank you. And my last question was, with the new guidelines, are we seeing changes in insurance coverage for von Willebrand treatment?
Yeah, so NHF actually and ASH have been working really closely with the regulators. The goal, we know there was a previous guideline from 2007 that had said type 1 von Willebrand disease was only if your level was less than 30. And so we were seeing people with levels between 30 and 50 not getting appropriate coverage. And I think that has improved. And the hope is that coverage for factor, for prophy, or for bleeding will also be improved with this. Again, I think a lot of people in Europe are like, why is this an issue? This shouldn't be an issue, and the prophylaxis recommendation should have been everybody needs prophylaxis, but we're still hoping that this will solve some of the problems. I know we still spend a lot of time arguing with insurance companies, but I know NHF and ASH are working at a regulatory level to kind of, cut off some of this discussion and make this a more this needs to be covered and you don't get to not cover it. So that is our hope.
Great. Thank you, Dr. Flood. There is a question in the chat. Can you explain vWD sequencing for babies?
I assume this means sequencing for little like infants or prenatal testing. I'm going to assume it's live infants, but maybe if that's not the case, clarify for sure. So if infants, okay, if you have a family member that has von Willebrand disease and you know the genetic defect, then it's really easy. Because if you know the genetic defect or the genetic change, I should say, I don't want to say defect makes it sound like you're defective and mutant makes it sound like you're an alien. So the current terminology is genetic variant, which I think also has implications if you're a Marvel Universe follower, but maybe those are good implications. So if you know the genetic variant in the family, then it's really easy because you just test the baby for that same variant. And if it is a straightforward, like a type 2 von Willebrand disease, where there's a single genetic change that is causing the von Willebrand disease, then genetic testing will give you an easy yes or no. If the family variant is not known, it can be a little harder, but you certainly can do von Willebrand factor gene sequencing. There are places that are actually recommending like everyone get their whole genome sequenced for any possible anything. The problem with von Willebrand disease is there are certain genetic changes that it's very clear what they do. However, there are other genetic changes that it's not so clear. The von Willebrand factor gene, there's areas that are really highly variable. And there's areas where years ago we saw a change and said it caused problems, but it turns out that that variant is actually really common and probably doesn't. And I'm looking ahead at questions. I also have to confess that there's a couple genetic changes that show up as type 1 or type 2A or type 2M, and sometimes all in the same family. So most of the time you're going to get a clear answer from the genetic testing, but it's not 100% of the time, which is I think why for type 1, we generally still do plasma testing and not genetic testing. But if the family variant is known, that can be an easy way to do it. You can do genetics off a cheek swab. You can just swab the inside of your mouth and it doesn't involve a blood draw. There are some potential insurance and ethical questions regarding DNA testing in infants that can't consent. I think DNA testing is becoming very ubiquitous. Right now, the government has protected that you cannot have your insurance change based on your genetics. I worry that that's not going to be the case forever, but I also think for von Willebrand disease, it's probably not, I mean, there aren't the implications like there are for diseases like Alzheimer's or breast cancer, things like that, where you're worried about something that's going to show up many, many years in the future. So I don't think there's a major reason not to do it. It's just in some cases, you may not get a precise answer from it, particularly for type 1. And that is super annoying. But again, if you know the defect or the change in the family, then you should be good. Genetic testing for somebody who has been unclassified, again, right now, I think the treatment of von Willebrand disease really doesn't depend on what the genetics are. So I don't know that it's mandatory to get genetic testing if you already have some sort of diagnosis and are being treated adequately. It's definitely, a lot of people are curious. And I believe Athens has a study that's now open that you can get free genetics through. Hemophilia has been doing free genetic testing for a while, but I believe we now have it available for von Willebrand disease for people that are interested. That being said, the type 2 variants are tricky and tend to bleed into each other. It is, the classification is interesting from a molecular biology perspective. I'm not 100% sure it's necessary from a clinical perspective. And there really are variants that are unclassifiable. And it's really annoying. But we now have multiple publications that show that there are these variants that sometimes look like a 2M, sometimes look like a 2A, sometimes can even look like a type 1. So from an intellectual standpoint, it might be fun to know what your genetic change is. But if you're currently getting adequate treatment, I'm not sure that it's going to add anything from a treatment standpoint. But it is always interesting to know. So if you're super curious, let me know. But I also have had multiple people in these families that are truly unclassifiable.
Great. So it looks like that you addressed the questions in the chat from Jay, correct?
I'm watching the chat too.
Yeah.
Sorry.
All right. Awesome. Perfect. No, Crystal, you have a question.
Hello, how are you today?
Good morning.
So I went recently for genetic testing and found out that I'm a carrier for von Willebrand. I don't currently test positive for it, but I'm still a carrier. My question is, my daughter has factor 10 deficiency. Is that something that can happen? Or is von Willebrand something that now later in her genetic future, if she decides to have children, that she now needs to look out for?
Yeah, so von Willebrand disease is common enough that you can definitely statistically have multiple coagulation problems. And it might be that it is super, like the genetic change is something that doesn't affect you unless there's something else going on. So it certainly could be something that we can absolutely see it in combination. We've seen it with, you guys have factor 10 deficiency in the family. We've seen it with hemophilia, other bleeding disorders. So it's not completely unheard of to have multiple in a family. And actually, it's possible that some of these people with just slightly low levels, the bleeding is based on what combination of other clotting factor protein changes you have. And so maybe having a von Willebrand factor level of 45 is okay, unless you also have an issue with another clotting factor protein. It is, I mean, I don't want to necessarily recommend genetic screening of her dates to see what potential combinations you could get in the infants, but it is certainly something where you could potentially have a baby at more risk of bleeding. So just to be aware of. But there's also a lot of other modifier genes. So it's possible maybe you could inherit a modifier that makes things better. But yes, we've definitely had all sorts of fun combinations with von Willebrand factor and something else because it is so common.
Thank you.
Hopefully that helped. And I know some of these questions are getting vaguer answers than you guys would like. And part of that is just the problem with von Willebrand factor genetics. Although even in hemophilia, there's a couple of variants that don't always behave. So it's not just VWF.
Thanks, Dr. Flood. I know we're a little bit over time, but is there any other questions? Great. If you can come on up. Yeah, sorry we can't show the screen. I think it's because the projector is hooked up to the computer and it's going a little wonky here. So you can imagine what everyone looks like.
You're welcome to share my email. Usually I would hang out afterwards because sometimes people have questions they don't want to raise in a group, but I'm happy to hang out on Zoom, or you can share my email if people want to hit me up in private.
Thank you.
Hi, Dr. Flood, thank you very much for the presentation. I just had a quick question regarding this, with the strike down of Roe v. versus Wade. And in states that the law is not clear, what about women giving birth and they're at risk, personally at risk, bleeding? Has there been any clarification to the medical profession on what they can or cannot do, and stay within the confines of the law so to prevent a woman from bleeding out in pregnancy? I'm really concerned about this. because the law is so vague in some of these states, and practitioners don't know what to do, so they're avoiding treatment altogether. So I'm wondering if you know of any efforts to try to educate the medical community.
Yeah, this is an issue that I think a lot of us are worrying about right now. There are definitely recommendations for treatment of patients with von Willebrand disease surrounding delivery and postpartum bleeding that could also be applied in that situation. I don't know that, and I have not heard if NHF is going to come out with something specific to the recent Roe decision, but it is a major concern. And we know that many people have postpartum hemorrhage with von Willebrand disease. I mean, I didn't mention that recommendation, but there is a recommendation for treatment in those situations. And there's certainly efforts around education for that. But that is really just around anyone who's giving birth with von Willebrand disease. So I don't know if NHF is going to address this. I think the medical community is sort of in shock right now because of this issue. So I will bring it up at NHF and see if they will put out a statement. It may already be in the works. But yes, I think there are a lot of concerns about how the current laws are, what is allowed, what is not allowed, and it varies state to state at the moment, which is also very concerning. Speaking of health equity issues, this is obviously also a major health equity issue. So I share your concerns and I don't have a good answer right now.
Thank you. Any other questions? I don't think there's any other questions, but Dr. Flood, we can share your email with everyone, and the recording of this presentation will go up on YouTube. I have a very important question though, and I've been debating on this. The avocado behind you, is it a painting or is it a cornhole?
It is a painting. Okay. I have a 9-year-old who fancies herself an artist, and the artificial zoom backgrounds, I move too much. And so it goes like in and out of focus. And so it's easier just to leave my office background up.
Yeah, no, I love it. It's adorable. I just couldn't tell if it had a hole in the middle.
No, it's just a painting.
Well, it's awesome. It's awesome. Well, thank you so much for spending time with us on a Saturday morning. We so appreciate it. And many of us will see you at NHF.